Okay, I think we can get started. So good morning and good afternoon, everyone. On behalf of ASCP, I want to welcome you to this month's Pathology Echo session featuring Dr. Marcelin Mugabe. Dr. Mugabe currently works as an anatomical pathologist at the Namibia Institute of Pathology. He holds a bachelor's degree in medicine and surgery, as well as a master's degree in anatomical pathology. He has over 14 years of experience as a medical doctor and over 6 years of experience as a pathologist. After graduating from medical school from the University of Rwanda in 2010, he worked as a medical officer for 3 years in public hospitals in Rwanda before starting training in anatomical pathology in 2013 at the University of Rwanda, from which he graduated 4 years later. After graduation, he worked for 2 years as an anatomical pathologist at Butaro Teaching Hospital and Butaro Cancer Center of Excellence in Rwanda before joining the Namibia Institute of Pathology in 2019. Dr. Mugabe is a member of the Rwanda Society of Pathologists, for which he served as executive secretary in 2019. He's also a member of the APEXA, as well as the International Academy of Pathology. His fields of interest are breast pathology, skin pathology, and infectious pathology. Dr. Mugabe will share 2 case studies today on mimickers and histology, and we just want to welcome Dr. Mugabe to our session. And please go ahead and get started, Dr. Mugabe.
Hello, everyone. Good morning or good afternoon, depending on where you are. As Adabi said, Dr. Mugabe, and I have 2 interesting cases which I want to share with you in this first pathology echo session of the year 2024. Can everyone see my screen?
Yes, but Dr. Mugabe, if you can make it in the presentation mode.
Yeah.
Yes, that's perfect. We can see it now.
The 2 cases, one case, a benign condition mimicking cancer, and another one is just a benign condition which was looking differently clinically, and then which came out to becoming something interesting after histological evaluation. The first case consists of a 68 years old male who presented last year in May with widespread skin indurated plaques with erythroderma for more than 1 year. The clinical impression or clinical differential diagnosis was eczema, mycosis fungoides, or psoriasis. They took a biopsy and in histology, we received a skin punch biopsy measuring 3/2. On microscopy, we can see that it was a skin tissue consisting of epidermis and dermis with a kind of psoriasiform acanthosis. One should also tell that this is a thinning of the suprapapillary plate, maybe here also. And you can see also this diffuse inflammation in the upper dermis and around some of the adnexae. On a medium power, we could appreciate this confluent parakeratosis without hyperkeratosis involving the entire stratum corneum. We thought that this was a Monroe abscess. So the inflammatory cell infiltrates consisted of mainly lymphocytes. At higher power, we could see their lymphocytes, everywhere, and we can appreciate this epidermal exocytosis, these lymphocytes going into the epidermis. One can also appreciate this tagging of the basal keratinocytes. So having these features of psoriasiform acanthosis, parakeratosis, absence of granular cell layer, and absence of overt atypia of the lymphocytes, we concluded in a diagnosis of psoriasis that time. Then the patient got treated with I don't remember the molecule. So he got treated for 2 months without improvement. But then after two months, he presented again to the clinic with generalized body weakness, weight loss, splenomegaly, with leukocytosis of 27 and severe anemia of 4. The peripheral blood smear showed moderately mature lymphocytosis. Lymphocytes was quite maybe in a normal range. It was 28%, but with increased atypical form, 7% atypical form presenting as looking like Sézary cells. The trypin biopsy also showed increased CD4 T cell proliferation. So flow cytometry also highlighted that the majority of lymphocyte were T cells, only 0.1% being B cells. And the CD4, CD8 ratio was very high, 35/1. Having this information from the hematology department, then we thought maybe it is better to review the biopsy. Then when we reviewed the biopsy, then it was difficult for us on histology only to conclude on something non-benign. So one thing we could tell for sure it was this tagging of lymphocytes. This lymphocyte tagging this basal keratinocyte of this reterage, also in other areas, and this exocytosis of these lymphocytes, but no atypical form, no bean-shaped lymphocytes, no porphyria abscess. So other features of which would make us think of mucosis fungoides was not there on histology. But then we said, let's apply some immunos to see. Then we applied a CD4 or a CD3, which was positive, diffuse and quite strong. We see all these lymphocytes at the epidermis, and also those small ones which are migrating to the epidermis. They were stained brown, meaning that the CD3 was positive. The same was the same image was for CD4, which also highlighted a positivity. I apologize for the quality of the slides because the biopsy folded, but you could appreciate the positivity of this CD4 marker. Unlike CD8 and CD20, which became completely blue, which means CD4 and CD8 were negative. So after all these information, clinical presentation, hematological findings, histological finding, immunohistochemical stains, we conclude that this, we conclude with, together with hematology department and the hematologist, we called it mucosis fungoides with bone marrow involvement. So then, as a lesson, we told ourselves that whenever clinician think about mucosis fungoides, we have to think of exploring all the clinical and laboratory information which could help us make a proper diagnosis in order to better manage our patient. The second case,
Dr. Mugabe, if I can
yes,
stop you for 1 second, just wanted to remind the audience to please put any questions that you have in the Q&A box at the bottom. And then Dr. Mugabe, when you're ready, you can click on the Q&A box on your side as the host, and you should be able to see the questions.
all right.
Okay, thank you.
Then this the second case is 41 years old female who presented with external genitalia, extensive papillomatous growth, and the clinical impression was condyloma acuminata. In histology, we received 3 skin biopsies, together measuring 40/25. On microscopy, we could appreciate this prominent acanthosis. You can see here that this skin maybe is normal thickness, but the rest is heavily, markedly acanthotic, and one might even call it pseudoepitheliomatous acanthosis. But at higher power, we could see that in the epidermis there are numerous neutrophilic infiltrate, however, no coinocytosis identified. This is another picture highlighting the beginning of ulcer, dense band-like inflammatory infiltrates with a kind of pseudoepitheliomatous hyperplasia. The same picture, medium power, highlights this ulceration and a mixture of inflammatory cell infiltrates. Then the question, what constitutes those inflammatory infiltrates? Are they neutrophil, lymphocytes, plasma cells? Then at higher power, we can see that there are numerous neutrophils, plasma cells, lymphocytes, and also quite a big number of eosinophils in between. So our impression, maybe we told ourselves, was it a hypersensitivity skin reaction? Was it syphilis? Was it another STI? And then straightforwardly, we asked Treponema pallidum IHC stain, which came out being like this. This is lower power, medium power, and high power 40x. This is, as you can see, it's extensive brown staining all over this biopsy. And at higher power, we could tell that all this brown staining consisted of these bacterial rods consisting of Treponema pallidum bacteria. So we concluded at syphilis. Then the question was it primary or secondary? And then because clinical presentation, the clinician was thinking about condyloma, so then we concluded it might then be a secondary syphilis. The other name of secondary syphilis presenting that way clinically is also condyloma lata. A lesson here, we should say that to always think about STI in case of ulceration and dense mixed inflammatory cell infiltrate in biopsies taken from external genitalia or perineal area, and act accordingly. Dear colleagues, this marks the end of my small presentation. I thank you and welcome questions and comments. I can see.
Thank you so much, Dr. Mugabe. As a reminder, please enter any questions you have in the Q&A box. It doesn't look like we have any at this time. You have a few comments in the chat box.
Yeah, I can see Dr. Moses Maria. Yeah, he concluded as mycosis fungoides, the first case, and Sheila Segura thanking us. Thank you, Sheila. Yeah. Oh, yeah. And then how did you know it was herpes?
We're not able to use the audio function for the webinar, so Shayla, if you're able to type your response.
Oh, okay. Okay, thank you, Sheila. Mhm.
And do we have any other audience members who have had similar cases like the ones that Dr. Mugabe shared that they would like to share with the rest of the participants? Please feel free to. Okay, we have one question, Dr. Mugabe, in the Q&A.
Let's see.
Can you see the question? It says, for the first case, epidemotropism appeared difficult to identify on H&E until IHC was presented. Do you have any comment on the approach?
Thank you, Moses, for the question. Yeah, although it appears difficult to appreciate on HNE on this picture, I can assure that on microscopy and when we were viewing slides and moving all over the slide, we could appreciate it all over mild, but we could tell it was there. But this is the problem of only presenting pictures. Sometimes you don't see the exact thing the examiner have seen under microscope. So I don't see any other approach we can use other than just examine carefully the slide. Thank you.
Okay, great. Thank you, Moses, for the question. Are there any other questions from the audience? Please enter them in the Q&A at the bottom of your screen. So we have another question that
Okay, Moses is also asking, also in the event of where B markers were positive, what would be the conclusion? For me, I think if both B and T cell markers were positive, I would examine the proportion and see which one is stronger. Then if the the B cell are also in a big number and no ATPR, then I would conclude in just reactive cells, not malignant cells. Then I would continue consider the previous diagnosis of psoriasis. Thank you.
Great, thank you, Dr. Mugabe. Are there any other questions from the audience? We still have a bit of time. Okay, I think we've answered all of the questions. If there are no more questions from the audience, we can conclude the webinar. And if you do think of anything you would like to ask Dr. Mugabe, please feel free to share it with Dr. Milner, and we can make sure to get it over to Dr. Mugabe for his feedback. I want to thank Dr. Mugabe once again for this excellent presentation. Very interesting, and thank you all for joining. So have a wonderful afternoon and evening.
Thank you, Debbie. Thank you, everyone, for attending this session. We hope to see each other again during the next session.
Thank you.
Bye-bye.